So good afternoon everyone. So this topic which we have today is immunofluorescence, all about challenges in reporting. So it's more of a general topic, so I thought of covering a lot of basic things in immunofluorescence and mainly of course the autoimmune testing and immunofluorescence lab and what we talk about. So the first slide that I would like to begin with. So the first thing which I want to start with is that when it comes to immunofluorescence as a lab, our first limitation or a challenge for an immunofluorescence lab everywhere was the microscope, the fluorescent microscope that we had. So earlier, say a few years ago, we had used to have microscopes where we had mercury arc lamp, and with mercury arc lamp, that itself gave us a lot of challenges and limitations. In terms of there was a waiting time for that lamp to heat, and for it to come to some optimal level so that it gives you the right fluorescence and the right kind of light. So there was a lot of waiting time. In that, once it has reached the optimal time, you have to finish all your work during that time, because if you shut the microscope in between, again there will be a wait time. So there were a lot of these challenges. In order to interpret the things properly under the microscope, with mercury arc lamps we always required a dark room so that we could appreciate the fluorescent patterns in a much better way and a correct way. But now we have moved ahead. So now we have LED source lights and microscopes with LED source lights, and with LED source light, all this whatever I said doesn't apply anymore. The wavelength and the light, the way it is emitted through LED is a constant, stable, consistent. There is no waiting time and there is no mandatory requirement for a dark room. Though dark room always would be advisable, always would be preferable, but now with LED with such a consistent good light source, that requirement is not that mandatory anymore. So I think that itself we have progressed further in terms of the science and in terms of fluorescent microscopes which are available today, that we have evolved further. So that was the first thing that I wanted to highlight. Going ahead, most of our kits in autoimmunity and what we use today, mainly we have only one fluorescent label that we use, and which is FITC. So the filters and everything is also very, very toned down, and it is very custom made for that application as autoimmunity tests and immunofluorescence. So my entire focus is only on this. I am not going to talk about microbiology applications and fluorescent microscopy, but I am going to more focus on the autoimmunity only. Okay. Having said that, now let's begin the basic test in autoimmunity. So before I begin into the basic test of autoimmunity, we all should come on this very common, very basic understanding, which I think all of us needs to be aware about, and we need to educate our clinicians as well. Because I am sure that each one sitting in this room would have come across with a query from the clinician that you have given me an ANA1 plus spectral positive, but the patient doesn't have anything. And they doubt our reports as to you are giving out a high positive reports or a false positive report. So now this is one thing we all need to educate ourselves and the clinicians as well, that autoimmunity and autoimmune phenomena is a normal phenomena. As age advances, we all tend to develop autoantibodies, but these autoantibodies is developed as a normal phenomena as the age advances. There is a difference in the autoantibody which develops as a part of a disease versus what happens as a part of a normal phenomenon. So, by and large, if we have to talk in terms of technicality, they are often always of IgM types, and those which have got a very low avidity. That is a normal phenomena as an autoimmune phenomena. While those which are with the disease are often always of the IgG type, and the one which are of high avidity. And the most important thing, that just that antibody being positive for a person doesn't mean that the person is having a disease. What qualifies that the person should have a disease or has a disease is that we have to document the end organ damage or the damage to the organ in which or in the context in which we are talking about the autoantibody. And that needs to be documented, which may require some other ancillary tests to support that yes, there is an end organ damage, and only then we will qualify it as a disease. A simple example I would say, in a lupus, ANA positive, what I would require complementary is in terms of disease damage would be say C3, C4 activity complement. I will look at that, whether or a CRP, whether there is an activity going on, right? So just an ANA positivity, yes, it is one of our important screening tests for diagnosing autoimmune diseases, but it has to be clubbed. The interpretation has to be clubbed with what are the clinical presentations and probably also with some other ancillary tests. Okay, so this was another very important point which I wanted to emphasize. So having said this, we all know that autoimmune diseases is a multifactorial disease, and all three areas that you have a genetic predisposition, there will be the environmental factors, and there will be obviously the immune part and the immune system part, which plays the interplay between each other for a person who have a autoimmune disease. By and large, we classify all these autoimmune diseases as organ specific or systemic, and you all know this is a standard, any textbook would give this as a classification of the organ specific and systemic autoimmune disease. So what are the laboratory tests that we have, irrespective of whether it is an organ-specific disease or a systemic autoimmune disease that we talk about? So the first thing is a screening test for an autoimmunity or an autoimmune disease. And the number one test which we talk about, of course, is antigen antibodies. Besides ANA today, we will have other tests which is your DNA as well as ANCA. When we talk about your systemic vasculitis, of course, the ANCA becomes your first screening line of test. When you talk about a general systemic autoimmune disease, ANA becomes the first screening line of test. And then once the screening test is positive, you need to go in with the second line of tests, which would be further drilling down into identifying what is the specific autoantibody which has given rise to the positivity or contributed to the positivity to the screening test, and which would further give us or pinpoint the exact nature of the autoimmune disease that we are talking about. So, by and large, our concept always has been a two-step approach for diagnosing most of the autoimmune diseases. A screening test and then another additional, I will not say confirmatory, but an ancillary test, which will support the screening as well as the clinical diagnosis. So, whatever I have written there as ANA, GNA, ANCA, ENAs, now that is exactly what I want to go slightly into details and touch upon each of them, and what are the problems or challenges that we face in reporting in each of these tests. So ANA. So ANA, our basic methodology, which is as per recommendation also by the American Rheumatology Association, and it still holds true even today, is indirect immunofluorescence. So indirect immunofluorescence is the recommended method for screening ANAs and as an ANA test. Very clearly written in most of the guidelines. They do not recommend ANA by ELISA as a screening test, but they recommend ANA by indirect immunofluorescence as the methodology. So indirect immunofluorescence is nothing else but I use substrate, a tissue substrate. Now this tissue substrate also over a period of years has evolved. Initially we used to have animal tissue substrates. So now we have cell lines available with us, and now we have Hep2 cell lines which are specifically used in our ANA biochips which are available to us. Now various companies give us various combinations. Some companies give us a combination of both tissue substrate as well as a Hep2 cell. Some give us only Hep2 cells as an option available for us to choose for doing indirect immunofluorescence for ANA. Now either of them can be used, but I personally feel a combination of tissue substrate plus and Hep2 simultaneously being used in a biochip gives us a better advantage. There are certain additional advantages that we can talk about, which also I will highlight in subsequent slides. So that's the basic principle that we are talking about indirect immunofluorescence, that the tissue substrate is exposed to the patient's serum. If the serum contains antibodies, they will react with the specific antigens, and this would be tagged by a fluorescent dye, which mainly we use is FITC for our fluorescent microscopy, which we can then see as the fluorescent staining pattern to call it as positive or negative. Now when we do this, when it comes to ANA by IF, there is a concept of sample screening dilution. Now here again there is a lot of confusion amongst various companies. If you go through literature, everyone talks about different sample screening dilution. One company would talk about something like 1 in 80, another would talk about something like 1 in 100. Now practically if you ask me, there is no difference between 1 in 80 and 1 in 100. If you yourself do it in your own labs actually do a doubling dilution as 1 in 80 and this triplicate dilution as 1 in 100. And actually, if you see the same sample being tested in such dilutions, you will not see any difference in the fluorescent patterns. It is practically the same. And you can do it yourself. I have also seen this myself. And the best way to check this is use the control. Because control intensity we already know. So that variability is out. So use a control and do this and you yourself will know 1 in 80 and 1 in 100 actually doesn't make a difference. But since the kit insert mentions a particular sample screening number, I cannot change that. I need to adopt what the kit instructions and the kit manufacturer is giving me. So I need to adopt that particular sample screening dilution, whatever the kit insert or the manufacturer is saying so. But this is just a sharing the point that 1 in 80 and 1 in 100 actually doesn't make a difference at all. Okay, so what is this sample screening dilution and why? Coming to that. Now the reason why is what I said in the few moments ago, that since autoimmunity is a normal phenomenon and since you tend, as age advances, we tend to develop these autoantibodies, we need to mask them out so that the false positivity is reduced in our testing methodology automatically. And that's the whole concept of sample screening dilution. Why it is to be done. Not only that it is to be done and adopted, we need to write this in our report formats also, that this result that I have reported is at using this sample screening dilution. I think most of the labs don't write it in the report format. We should write that because it becomes more clearer then to the clinician as to what sample screening dilution we are reporting the result. Now I pulled out this very good article, which is an Indian article, which talks about again validation of this sample screening dilution. So they have taken various age groups as normal patients, healthy patients, and you can see they are talking about by and large 1 in 80 as the sample screening dilution, as doubling dilution, where beyond that, that normal component or the normal part of a normal healthy autoimmune phenomena can be easily removed. So this article had used a doubling dilution and they talk about 1 in 80. But I have already clarified that 1 in 80 and 1 in 100 is almost the same. Okay, so just wanted to clarify and confirm this part as to what is sample screening dilution. Now this I have explained with reference to ANA, but the same logic applies to any other autoimmune test that I am talking about. The same thing would apply for dsDNA, same thing will apply for your ANTA, same thing will apply for your asthma and so on. The logic and the basic approach remains the same. Okay. Another thing in ANA is that we have to identify that yes, this is positive, but we also have to give what is the pattern. Because each pattern is classically associated with specific autoimmune disease. So one needs to get trained in identifying these patterns. So I think most of the companies give us controls, positive controls, and they keep on changing it periodically, which by and large, cover the entire spectrum. And using that positive control, aliquoting that positive control, and using that as a training tool for our own team to keep on identifying the patterns correctly is the best way to do it. That we can use them for teaching and training in identifying these various patterns. Now when I say patterns, and as I have written there, I have shown some of the classical ones as the homogeneous pattern, rim pattern, speckled pattern, the dots, centromere. When it is very clean and clear cut, a single pattern, usually there is no issue. We are able to cleanly identify it. But our patients are not always coming to us, which are absolutely clean and simple. Many a times we tend to have some mixed patterns that we see. So how do we address an issue or a case where you see a mixed pattern? And I think the best way to do that is you put and see and observe the patterns in serial dilutions. When you do that, as you increase the doubling dilution of the sample, the predominant pattern will stand out more prominently and the one which is not so important will go away. So that will help you in identifying which is the correct and the predominant pattern which should be reported, and the other one which you are seeing preliminary at 1 in 100, which probably is an additional feature, but how important it is or how significant it is, it will help you in doing so. This is one way to address this issue of mixed patterns when we see in ANA. Another way to address this is when you see these mixed patterns, many a times if you observe it carefully, you will see that you tend to see these mixed patterns along the edges of that biochip, but as you come to the center of that biochip, you will not see it. So the very fact that you are seeing it only on the edges of the biochip and not in the center means it is some false reactivity, or there is some washing which is inadequately being done, which is causing this interference of mixed pattern that you are seeing. So this is another tip or another way that we can resolve these issues of mixed patterns. Yes. Third is when we have these biochips which are of say 5 or 10 that we are using, and if I see it on the third number, a mixed pattern, what was the pattern in the 2 or 1? So is there a carryover, and is there a carryover effect which is probably causing this interference? So if you look at it from this practical aspect, the issue of mixed patterns in an ANA can be easily resolved. So I am sharing, this is what I do practically, and I think for me most of the times it has helped and resolved the issues of mixed patterns. Still, also if we are in doubt, the best thing is then let it be seen by a second observer, preferably a senior person who would throw better light on what you are thinking. Yes? So I think these are the ways that we can address it. Another third part of your ANA reporting is the intensity. So now we will say that it is positive, negative, we will identify what the pattern is, and our third part is the intensity. Now when it comes to intensity, again we need to do serial dilution and then to save. So whatever we are saying as 3 plus in 1 in 100, now I keep on doing serial dilution till I reach a 1 plus positivity, and that 1 plus which I see is my endpoint titer, or one endpoint that I would report as titer. Now here also there is a way out. There are companies who have come out with a which is a more cost effective way also, which we would talk about as an estimated titer also, and I think that has been best time tested and the best way being done, especially in ANAs, not so done well in terms of ANCA or asthma or so on, where probably we will have to keep on doing actual endpoint titers. But for ANA, we can use a concept of estimated titers. So if we do this trial and error and best way again is to use the control, because the control intensity which is given to us is 4 plus. So you do your own endpoint actual titrations and see that at what titration this intensity becomes 2 plus, this intensity becomes 3 plus, and then you can correlate it the same way with the patient sample. So you can then apply to your patient sample. So at 1 in 100 only, when you are seeing it as 2 plus intensity positive, then you know that it correlates with 1 in 640 for example, and you need not actually do an endpoint titer. That's what I am trying to say. And when you don't do an actual endpoint titer, that is what you will call it as an estimated titer, because you have not actually done it. So you write it out also on the report that what you have given it as an estimated titer. So you are not lying to anyone. You are giving the matter of fact as to what you have done. But at the same time, internally you also have an evidence that you have cross-verified this, that it tallies. And that though you have taken this shortcut of not doing an endpoint titer, but still that estimated titer tallies with your endpoint titer. And you need to keep on validating it on a periodic basis. So that is also a way where some companies officially recommend it in the kit inserts while some companies don't. But even if those companies who don't recommend it, we can always use this logic and have our internal validation and put it in place. Okay, so these are the things which I would say for the ANAs. Those are the sensitivity and specificities for the various patterns that we talk about, which is from any standard literature, which you would find. Okay, so there is a new pattern which has come up now, which we all should know, and that is DFS 70. Now, the point which I raised a few moments ago, that many of us would have come across this question that you have given ANA 1 plus speckled positive, the patient doesn't have anything. There have been now enough evidence and enough review of literature using this pattern, that if you go back and actually see how many of those 1 plus speckled that we reported, actually a small chunk of them actually would have been this pattern. The only thing is that time we were unaware of this particular pattern that it exists, and hence we never used it or we never reported it. But now that this pattern exists, we need to adopt it in our reporting schedule, so that some of the over-reported 1 plus spectors will be reduced. Now, what is this DFS70? Now, DFS70 pattern in a very simple way is, it's a speckled pattern, but a classical definition of a speckled pattern is that the mitotic cells are negative, always. That is what is the classical speckled pattern is. So here, it is a speckled pattern, but the mitotic cells are also positive. So that's the key, that you have a speckled pattern, but with mitotic cells also being positive. That is a hallmark of DFS70. And there is a most likely possibility that it is a DFS70. So we can go back and take what is the history of the patient and ask why this test was recommended for this patient. And most of the times we will find that many of these patients would have non-specific symptoms, and the most common disease where it is being associated with is non-specific dermatitis, non-specific atopic dermatitis, and so on. So they are non-autoimmune diseases that the patient is this pattern is related to. This pattern is not related to any rheumatic process or rheumatic disease. So that's the importance of this pattern, and one needs to incorporate it in our routine report. Now, going ahead, probably we would also have ELISAs for DFS70, but I think they are not readily available as far as my knowledge goes as of now. And I think it will not be cost effective, it will increase our turnaround time also. But rather, we can identify it on morphology. It is easier to identify it on morphology and put it on record that there is a possibility of DFS70 and communicate to the clinician and the patient accordingly. That should, I think, suffice. Another caution, though I say this, is that one should also take into consideration the intensity. I am not saying report DFS70 when you have a pattern which is say 3 plus or 4 plus. If it is 3 plus or 4 plus, then it is less likely that it is DFS70, but there is probably some another primary pattern which you can identify by further dilutions. So DFS70 pattern, though I said that you can report, but by and large I have not seen it more than 1 plus as a positivity, and where I clearly call it as a non-rheumatic related AMA pattern. Okay. So that was on the new pattern and an update, and one should incorporate into our testing. So those were few points as challenges or the way that we can address issues in our ANA reporting. Coming to dsDNA. Now dsDNA, we had different methodologies for testing dsDNA, and over a period of years it has sort of evolved, as we had RI earlier as a FAR assay, then it evolved to IF, which is Clostridia lucidea, and then we had ELISAs. Now ELISAs also has evolved from conventional dsDNA ELISAs to a combination of dsDNA plus nucleosomal antibodies. So that's a simple chart to show you that if you use this congregate, which is a congregate of dsDNA conventional and nucleosomal antibodies, that is the congruence which would target identifying suspected lupus patients earliest in the course of the disease. And that is what our all aim is, to try and identify these patients much earlier. So that's the evolution of dsDNA that we have today as a combination of ELISAs, which are a nucleosomal plus dsDNA. And there are published articles now which show and prove that they have got higher specificity as well. So we have moved from RIA to IF to ELISA when it comes to dsDNA. And if you read a lot of current articles, most of the articles today favor this concept and favor using ELISAs as the primary modality for testing for dsDNA, because dsDNA ELISA also becomes important. Why? Because this patient you also want now to monitor, and when it comes to monitoring, the clinician always wants a number. They will not like a report which is just calling it as positive or negative. They would like to have a number, and ELISA is something which will give them the number and help them to monitor the patient. Okay, so that's the only thing which I would say on dsDNA. I will not go into the intricacies of IF into dsDNA because today in current eras that is not something which is recommended anymore. Because in 3D Lucidia also we have a lot of this permutation combination of the kinetoplast and mitochondria and only nucleus, and all this we had tough time in interpreting. But I think the best solution today is antigens. Okay. Coming to ENAs, that is extractable nuclear antigens. Now here the scope of various ENAs is continuously progressive and it is continuously evolving. If you read, say, 5-6 years ago what we talk about and spoke about ENAs, we used to talk about a standard 6 or 7 panel ENAs as a standard panel. But today it's no longer a standard 6-7 panel, it is much more. And as I said, it is still evolving. Now there are certain problems that we come across. Many a times a clinician prescribes these ENAs, but they write only one letter, like these JO1, U1RNP, RNP, SMRNP, right? So we as pathologists and our team, that is technicians, they need to understand what tests has been asked and what is to be taken. So some thought and some clarification on that. And I think the best way and the simplest way to remember this is this schematic diagram of ENAs. So here we have the Smith antigen. So this is the Smith antigen. This part, so it is one common molecule and there are different parts of this molecule against which, different epitopes of these molecules against which the autoantibodies are targeted, and then each of these autoantibodies are unique and they are associated with different kind of disease altogether. So they cannot be replaced, they are unique in its own way and one needs to know that and one needs to take the test accordingly. So Smith antigen is here. The same Smith antigen, another epitope is RNP stroke SM, that is SMRNP, and on this side is the U1RNP. So U1RNP is separate and SMRNP is separate and SM is another separate. Yes? Common confusion in most of the technicians do is the SMRNP and U1RNP is often considered same and the implications are totally different. SMRNP is something which is related to an SLE, classical SLE patient, but UNRNP is a hallmark antibody for mixed connective tissue disorders. So it is totally different and we just cannot interchange them. And we need to know and take the things appropriately and cannot have that mishap in our labs. In the same chart, what I have tried to write is also that these are the various ENAs and the methodology today, what we have and has best shown the best sensitivity and specificity is by ELISAs. But if you can see here, I have also written one more method which is Immuno. Now this is something which as laboratorians we need to understand this and again pass on this message to the clinician. Sadly, there is a lot of this, what should I say, wrong medical marketing which happens of 1100 rupees and 11 antigens or some crap like that. Yes? So, number of antibodies and antigen testing in one go or one test is not what we want and is not what is correct. What is correct is whether whatever you are doing, are we doing it with the correct appropriate methodology. So that is the thought and that is what I am trying to say here. And why we need to know this is because we are only then becoming answerable. Because your lab will report it by ELISA, that person goes in some other XYZ lab and he reports by Immuno. Now your result is negative, his result is positive or vice versa. Now clinician questions you as to which report is correct. Now he doesn't understand, he doesn't want to understand that these are two different methodologies and they have got their different sensitivities and specificities and you cannot compare, it is not apple to apple comparison. They don't understand this and they don't want to understand. So the only way is that we should be firm in what we are doing and we need to keep on educating our clinicians that this is what it is. And whatever I am showing you here, you can Google yourself and find out there are enough scientific published articles stating what I have shown here. Okay. So it is the same thing, further elaborated in terms of numbers. in terms of sensitivity, specificity, pulled out from some published article only. So now here, just wanted to highlight few things, why there is a difference. So again, conceptually, scientifically, if you try and understand, the way I showed you that diagram of the ENA of SM, RNP and UN RNP. So there is this antigen which we are talking about as a three-dimensional model. So when I talk about an antibody, and if it is something which is such a complex antigen, so this conformational structure of the antigen versus an antigen which has got a linear structure. There is a difference in a simple logical way. You can understand that an antigen which has got a linear structure can be easily put into simple things like an immunoglobulin. But an antigen which is complex and is having a three-dimensional structure will require a well where the antibody can react with that conformational epitope from all around in a simple way. Right? So that's the logic, and hence for certain antigens which are conformational, you will require ELISA, which is really the best methodology to use. Versus those which are linear, it doesn't matter then whether you use a immunoglot or whether you use a ELISA. So that's what again I am trying to say here. So if you see SSB, it doesn't matter whether it is ELISA or immunoglot. Almost the sensitivity specificity is the same. But if you talk about Smith antigen or UN RNP, no, it has to be ELISA. So that's what I try to bring here. While similarly, if you talk about Jo1, now Jo1 is a cytoplasmic antigen. Jo1 is a cytoplasmic antigen, right? It is not a nuclear antigen. Oh, I missed that one point. Sorry to say in ANAs. One more confusion is whether to report cytoplasmic positivity in an ANA report or not to report. Now, if you look at the guidelines very clearly say that cytoplasmic positivity has to be reported as a part of ANA. That's an advantage that we have of using ANA IF, which you lose in case of ELISAs. That's the reason, in fact, IF has been recommended for ANAs. Now, Jo1, which is a cytoplasmic antibody, and by and large, I can say this for most of the cytoplasmic antigens, immunoglot would work well. But for many of the nuclear antigens, immunoglot will not work. Yes, in a very generalized way, if I were to put a statement. Okay. Right. So, what is, having said all this, what are we thinking and what should be the current approach? So, the current approach today, when we talk about so old approach was a two-step approach, but today people are saying, why waste time? If my pre-test probability and my clinical suspicion is strong enough that this patient is having an autoimmune disease, I would prescribe ANA as well as ENA at the same time. Or still better, we can have our internal reflex strategy. If all ANA positive reports, we would communicate, do ENA, and both we will report together. Yes, so we are moving towards that both the tests to be done at the same time rather than as a two-step approach. So this is another way of looking at it, trying to again decipher based on the positivities what all various ENAs that we would like to do, and we can do this in liaising with the clinician and the patient, or we can have our internal lab strategy to do this reflex testing and report it on together. Okay. So that was on ANA and dsDNA that I had to share. Now something on vasculititis and ANCA. Now vasculititis, that's your basic classification that we all know as the three categories. And what we are mainly targeting and the test by which I can diagnose is of course this group. Unfortunately, we do not have any specific test for these two as of now till date. But we do have tests for this, which is mainly ANCA. So talking about your ANCA. Now ANCA, immunofluorescence, that's the understanding of our why that magic happens. It's like a magic that we could tell a child that initially it was looking something like this and now it has changed like this. So it is all because of the conformational changes which happen between the ethanol and formalin and the reactivity of the positively charged and the negatively charged our antigens, which is the myeloperoxidase MPO and proteinase 3. So it is because of the relative charges that these two antigens have. This change happens as we fix the cells in ethanol and as we fix the cells in formalin, and hence we see it differently. So the change, what I am trying to say is that the change, that is the antigen moving towards the nucleus or antigen remaining within the cytoplasm, that change has happened earlier only when the neutrophils were fixed by formalin or by ethanol. We are seeing it now differently after the reaction. That's the only thing. And these are the three common patterns that we would see or interpret on IF, and those are the common associations that we have. So that is what we know, and we all know the different challenges that we had with Anka on IF. And I think the best way to go to resolve, I felt, was always to have two observers when in doubt, and then to come out with a conclusion. And still also, if there is no concordance between two observers, best way is to fall back upon ELISA and then give a confirmatory report. And this is what we used to do and have been practicing. And if you look at the recent guidelines which has evolved for Anka, so there is a recent guideline which has come up of 2017 for Anka, and which is favoring direct first line use of ELISAs. So IF Anka slowly would be probably totally phased out, and we will totally switch over to only ELISAs, because ELISAs today have become very sensitive and specific for LPO and TMP. And that's the published recent article which talks about the same, which you can see showing a very good sensitivity and specificity. And the same point, as I said, clinician, when he wants a vasculitis patient monitoring, he wants a number, and it is ELISA which will give the number. Okay. The third part is autoimmune hepatitis, and that is asthma, AMA, alkaline. That's the last part which I will touch upon. Okay, so when it comes to autoimmune hepatitis, this is how the classification goes. And you all know that autoimmune hepatitis, it's a triad of these three. Either of these autoantibodies, that is serology, increase in immunoglobulins, and histology. A combination of all these three is the diagnostic triad required for suspected autoimmune hepatitis. Now here again the sample screening dilution and some debate and controversies on this. Now again, like ANA, most of them recommend either 1 in 80 or 1 in 100 as the sample screening dilution. But there are a lot of evidences where if you are talking about autoimmune hepatitis in the pediatric age group, then the titer, sample screening dilution titer should be lowered to as low as 1 in 20. And there have been a lot of publications favoring that in pediatric age group, especially when it comes to asthma, LKM1 and these autoantibodies, the lower titers are also equally clinically significant. So we need to change that. So based on the patient's demography, and if it is a child, we need to use a lower screening dilution and not the general 1 in 80 or 1 in 100. This is the point which I am emphasizing. Okay. Now, smooth muscle cell antibodies also has evolved over a period of time. This identification of asthma was basically on the combination of tissue substrates and the recognition of patterns within the various tissue substrates. So the commonest biochip, the combinations we use a stomach section, we had a kidney section, and we had a liver section. So classically we need to see VGT pattern, that is the vessels, the glomeruli and the tubules. And all three of them should show that classical positivity and fluorescence to call it as asthma positive. So this was very, very subjective, very, very labor intensive. What I am calling as tubular positivity, you may not agree, and you will have all these permutation and combinations of VGT, where one feels it is positive and one feels it is not. But that problem also got sorted out with now the advent of, as we realize that what is important in asthma. Asthma antibodies, again we realize could be of two types, one which are reacting against G-actin and one which are reacting against F-actin. And what has been published and approved now is the F-actin asthma is what is clinically relevant and is implicated in autoimmune hepatitis. So we need to identify only those. And those which are related to G-actin, yes, they are autoantibodies, but their clinical significance we do not know as of now. So for F-actin, what is now available is transfected cells by F-actin. So now I have that still in place of VGT pattern, but apart from that I would rely more now on these transfected cells, which if they are positive and they are showing this typical needle-like positivity, which is going out of the cell cytoplasm also, which is the classical hallmark of F-actin, and crossing across the nuclei also. that is the classical hallmark of an F-actin positivity as F-actin positive asthma. So that's a new development which has happened. So we should adopt this new development in the kits which will have F-actin incorporated. LKM1 is still based on our tissue architecture and the tissue pattern. So the best way is to look at the kidney, and in kidney you will not have the proximal convoluted tubules. They will be characteristically absent, will not show any fluorescence. Only distal convoluted tubules will show you fluorescence. Liver will show you a diffuse granular positivity for LKM1, but kidney will show you this typical pattern which is a diagnostic hallmark that can be easily picked up. AMA is a combination of your parietal cells in stomach and in kidney you will have all proximal as well as convoluted tubules both showing positivity, and parietal cells in the stomach as AMA-M2 being positive. Okay, so having told you all these things, I have just pulled up two small case studies. So this is one case study, 45-year-old female, comes to a general practitioner, 9 months, mild arthralgia. She presented 12 months earlier with an erythematous rash on the cheek and the nose. The rash was slightly oily and it seemed to respond to topical antibiotics. Development of joint symptoms raised some doubts of diagnosis of the rash, which appeared to be confirmed when an ANA test was reported as positive titer 1 in 8 ES separate pattern. So what do you think this patient is having? Do you think this patient is a rheumatic patient? Do you think this patient is SLE? Yes or no? So you feel it is yes. So let's see what happened to this, what was the follow-up of this patient. So this is the follow-up of this patient. So this residual rash which the patient was attributed to acne rosacea, and ANA was just an additional insignificant finding. Why? Because clinically the patient did not have anything to point towards an autoimmune disease. The same patient also had other radiological nodal evidences in other joints which point towards the joint pathology is osteoarthritis related and not to a rheumatic process. So the same point which I said, just ANA report as positive doesn't mean that the patient is having an autoimmune disease straight away. Yes, we need to look at what are the other clinical features which would say and favor to say that yes, it is SLE. Another case, 18-year-old male comes with malaise, lethargy, anorexia and weight loss. On examination has got mild synovitis along in the metacarpophalangeal joints. Investigation shows raised ESR, CRP and IgG levels, AST, ALT raised. ANA again 1 in 6 40 positive with diffuse and speckled pattern. dsDNA are also positive. Tests for asthma and AMA are negative. So what do you think this patient is having? Again, an autoimmune process, yes, or no autoimmune process? So autoimmune process, yes. So let's see what is the follow-up for this patient. So follow-up of this patient, autoimmune process, yes. This patient also had minocycline given to the problems which you can see here. Minocycline being given to him for 12 months, and minocycline is known to have or known to induce drug-induced lupus. One more thing should be done in this further to substantiate the diagnosis is anti-histone antibodies apart from ANA, which will further clinch and confirm the diagnosis that it is drug-induced lupus. Right? Okay. So these are some concluding points. That's the last thing that I am saying. Just a repetition of whatever I have said. So we need to have in ANA we need to report all those three. That is what it is positive, what is the titer and what is the pattern. We need to mention the sample screening dilution in the report. In comparison with IF and ELISA or IF and immunoblot, you will have discrepancies because these are two different methodologies, and ANA is a more generic screening test where all antigens are exposed to the serum, both cytoplasmic as well as nucleic, and hence IF would pick up much more autoantibodies than an ELISA or an immunoblot. I have already said that immunoblot sensitivity for SSB, SCL70 is good, but for dsDNA it is not good. A weak positive ANA, best would be to follow up the patient after 4 to 6 weeks and then take a decision. That because you can have transient autoantibodies also coming up, and that is the best way to rule it out. dsDNA, I said we are shifting towards ELISA. ANCA also I said we are shifting towards ELISA. Asthma and AMA LKM1 still remains on IF, and it depends upon a combination of that mosaic that we would use and identify the pattern to say it as positive or negative. And last but not the least, please remember it is important to treat the patient and not the serology. Thank you.